Good day. My name is Bonzo Reddick. I'm a family physician at the J.C. Lewis Primary Healthcare Center, which is a federally qualified health center and also a designated healthcare for the homeless site. I also serve as the chair of community medicine at the Mercer University School of Medicine, where I also served for 6 years as the associate dean of diversity, equity, and inclusion. I'm joined today by Angela Ward from the Game Changers, and I'll allow her to introduce herself as well.
Yes, it's such a pleasure to be here with you. I'm Angela Ward of the Game Changers. A little bit about me. I'm born and raised here in Georgia, South Georgia. I interview business owners, CEOs, also political leaders here in Georgia and also across America as well to discuss their company and what they're about. And also, I also went into looking into civilization and knowing more about what's going on with the community itself on a personal level.
And I'm glad to have a conversation with you today. I'm bringing greetings from Savannah, Georgia. And today, looking forward to the opportunity to talk about fallacies and dangers of race-based medicine.
Yeah, so let's just jump right in. Many people do not really understand the difference between race and ethnicity. Could you really explain that, Dr. Reddick, on just providing full knowledge on the difference between the two?
Yes, I see those two terms conflated a whole lot. So we're talking about from the standpoint of in the United States. It may vary from country to country, but in this country, we generally recognize 5 general racial categories and 2 ethnic categories. And you'll see the same system used for the US Census, for the National Center for Health Statistics. And the 5 racial categories that we recognize are white, Black, which is also known as African American, Asian, which has several subgroups that I'm going to mention in a moment, either Native American, Alaskan Natives, those are all kind of interchangeable terms, as well as American Indian. And then the last group are Native Hawaiian and Pacific Islanders. Again, there are several subgroups within those groups. So for example, you can be Asian, but you can also specify that you're Chinese, Japanese, Filipino, etc. So those are the 5 general racial categories that we recognize in the US. There's also an opportunity to select other if you don't feel like you fall into any of those racial categories. Now, in terms of ethnicity, in the United States, we keep it very binary. Either you're Hispanic or you're not Hispanic. Those are the 2 racial ethnic categories, excuse me.
Which is quite odd, I must say.
Very odd. So obviously there's people from all kinds of ethnic groups. We have people who are Persian or Arab or whatever. But in the United States, it's kind of either you're Hispanic or you're not Hispanic. And there are also other terms that you'll see used in place of Hispanic. You may see terms like Latino, or also Latinx as well. So those are either you're that or you're not. So a lot of times people refer to people who are Latino or Hispanic as a racial category. But again, in the US, as far as following the strict definitions, those are ethnicities and not race. You can only be one of the 2 ethnicities, but you can actually be any combination of race. So for example, you can be Black and white if you have one Black parent, one white parent, for example, and you could be Hispanic, or you could be Black, white, and not Hispanic.
So what is the dominating factor if you have that Black parent and the white parent? Because I'm gonna be honest, I always heard if you have a little bit of Black in you, then you're Black. So could you explain a little bit more on that?
Fantastic question. So and this actually gets to point, kind of one of the early core points of this discussion is that these definitions and your question is really more of a social and a political question. It's not a scientific question. So and my answer is not a scientific answer. It's more of a social and political one, because that definition changes over time. You're right. For many years, if you had they used to have the 1 drop rule that if you have any ancestors that identify as Black, then you're considered Black, no matter what your skin color looks like. And also, as far as who's considered white, that definition has changed over time. So for example, people that we identify here in 2021 as white, for example, if you have a typical Italian person or Italian American, or a Jewish person, they will probably be referred to as white. But in the early 1900s, they were actually not referred to as white. They were not included as white. So those definitions didn't change because we figured something out scientifically about Italian people or Jewish people or Irish people. It just turned out that socially they became what we consider assimilated into US culture, and so they were identified as white. So that definition, as far as if you have one Black parent, one white parent, or one Black parent, one white grandparent, are you Black or white? The definition changes, and again, it's not based on anything. Let's use one example. So
pretty much it's all political.
It is. It absolutely is. And speaking of political, here's one perfect example: Barack Obama. I kind of done presentations and joked around about this, that in 1988, Barack Obama was black, but then in 1990, he was white. And then by the time he ran for president, he was black again. The reason why is because the definition changed. Initially, you would consider if you had one non-white parent, whatever race they were, that's what race you were. But then they changed it to say, well, whatever race your mother is on your birth certificate, that's what race you are. So in Barack Obama's case, he has a white mother. So he went from being black to being white. And then later on, they changed the definition again to, well, whatever you say. So whatever you tell us, whatever you identify as, that's what race you are. And that's actually the current definition that's used pretty widely in scientific studies, medical studies, but also in the census or in the National Center for Health Statistics. So whatever you tell us is what we tell you you are.
Now, I do want to back you up a little bit on that. As far as in having your own determination, especially if you have that black and white parent, will that logically make sense? I mean, wouldn't you just say they're mixed? Do one have to identify as black or white?
And that's the funny thing, and that's why this is such a big deal in medicine, is because in medicine, we kind of have this scientific world where you have to choose one. And so in science, we kind of say, well, you got to fit in one. Tell us which one you are. And even though in the census, you have the ability to pick, I'm mixed, I'm black and white, when it comes to scientific studies, you're often lumped into one group or the other. And again, it's based on what the person tells us. So if you think about, I mentioned Barack Obama, if you think about other famous Black Americans who are of mixed race, Halle Berry, the Academy Award winning actress, or Patrick Mahomes, the NFL Super Bowl MVP, they both have one black parent, one white parent. They literally are the determinant of if they're black or white. So we kind of force them to choose one or the other. And literally in terms of medicine, if you're making medical decisions based on somebody's race, you're literally making a medical decision based on whatever the person tells you. And there's nothing else in medicine that we choose.
And really, you really can't make a determination off of that, because, hey, if I want to, I have a lot of white people in my family, especially in my mom. And I can say, well, I want to identify as white. So if there's, they say that diabetes run in black people, well, it don't run in me because I'm white, because I consider myself white. So I want to ask you something. Is there any biological or genetic basis for race?
None whatsoever. And what you said is a perfect explanation. In science, again, we look at hardcore facts, right? We look at clear evidence. So I can look at your chromosomes, your DNA, your genetic material, and say, I see this or I see that. I can run a blood test and say, I see this or I see that. This, again, is one of the few things, maybe the only thing I can think of in medicine, where we make medical decisions based just on what somebody socially tells us they identify as. And that makes no sense. That's not a genetic basis. That's just based on a social and political construct. And again, it's political because the example I gave you earlier, where if a certain group's not considered to be fit in with kind of the dominant society, then they're not considered white. But then if they do, then okay, now you're white. Not because we discovered any gene about Italian or Jewish people or Irish people, but because society as a whole just said, okay, well, you're accepted in society, now we consider you white. And again, people can just sort of decide one day they want to be white or one day they're not, in terms of people of mixed race. And again, that definition is not based on any science. It's not based on anything. I can't look at your DNA and say, oh, you're definitely white or you're definitely black. The way we define race in America, those 5 groups we talked about, there's no pattern to those whatsoever.
So is that just I guess, an American thing that they just made up? And what do you see in other countries? Do they define it more, I guess, better than America practices?
So it's highly variable. I definitely have been to countries where they do not recognize races, where their race is just based on their ethnicity, essentially. So I've been to areas of Honduras or areas of the Dominican Republic where people just didn't really understand that concept of race. It was kind of like, I'm Dominican. What do you mean? But are you white or you identify white as black? I don't understand. I'm Dominican. So there's some countries that don't. And again, it probably varies even within those countries from region to region. But I've definitely been to other places where people do not understand this concept of race and think that we are kind of silly for how we define race. And I've actually come to be on that same side based on the scientific research and the studying that I've done about it.
As a doctor, how does race how is race used in medicine today?
So it's used in a lot of situations. One of my favorite ones to discuss, there's a couple that I typically present with my medical students. So one of them is that for the test to measure people's lung function, we call it pulmonary function testing or spirometry. There's actually a device, the spirometer device, it actually has a setting where you can change the results based on the person's race. So if the person's Black or Asian, you'll get a different results compared to if they're white. And essentially what it does is for Black people, when their lung function is lower, it's more likely when you make that race-based setting, it's more likely to tell you that your lung function is actually okay, even when it's functioning at a low level. So for example, if I come in and I'm right on the borderline of being diagnosed with emphysema or chronic bronchitis, then if you use that Black race adjustment, then it may tell me that my lungs are normal, even though they're not normal, obviously.
Okay, pause right there. So if it's if the medical field is literally taking down a notch of Black people numbers, I don't know the best way to say it, but if there are borderline heart failure, and if there's some thermometer that is literally telling them that their heart is okay, how is that fair for Black people?
Yeah, and so this is in the case of lung, excuse me if I misspoke, in terms of lung function. But you're right, and there's a lot of issues with that. So I've heard stories about people who worked in factory or industry settings where they've actually had lung damage as a result of occupational exposure. And then when they go to collect disability or they try to get medical benefits based on lung injury, they're told, oh, your lungs are actually okay because you're Black. There have been a lot of situations like this. There was the National Football League recently had this race-based setting for cognitive testing. You know, there's been a lot of controversy about possible brain damage or what they call CTE in professional football players. And they've actually told some Black ex-players who were seeking benefits that, yeah, your cognitive function is lower, but based on the race adjustment, it's actually okay because there are expectations that Black people have lower cognitive function at baseline. There's other examples as well. You know, that in kidney function, there's actually an equation called the GFR equation that actually calculates your kidney function. But there's a separate equation for Black people and then a separate equation for everybody else. So it's kind of similar to the lung thing I told you about, where you can have a lung value, you can have a kidney value that's considered abnormal. You can have abnormal kidney function or what we call chronic kidney disease. But if you're Black, that adjustment will make it say, oh, actually that's normal. So what ends up happening is that Black people get referred to kidney specialists at a later date. They get placed on medications that can save their kidneys at a later date. And they're also less likely to be eligible for a transplant when they would definitely benefit from one.
And that's what I was getting ready to ask. That can affect, I know several people that died of kidney failure. So that's really, really bothersome for me. And one thing that I want to ask, you know, as a doctor, how do you feel? And as a Black man, how do you feel being in the medical field and knowing that these things are going on this level? Because this is mind-boggling for one, and also it has affected millions of people. So how do you feel about that as a Black male?
Yeah, so let me take you on since you kind of made it a personal thing, let me take you on a little bit of a tangent. Let me pull up some slides that I actually have here.
Great.
And I'm going to show you kind of from a very personal example. So let me flip through a couple of slides real quick. I'll come back to this slide as well.
No, that's no problem.
Just a moment. So you see here, I have kind of a white, Asian, and a Black bonzo. That probably sounds kind of silly, right? But on the right where it says Black bonzo, that is my actual statistics from about 4.5 years ago when I went in for my 40-year-old physical. So I actually there's a calculation that we use in medicine that calculates somebody's risk of heart disease. So there's kind of like a 10-year estimate of heart disease based on your age, your gender, your race, your cholesterol levels, your blood pressure. There's some other things that you can't see that are cut off. And so I went in for my annual physical. I got my assessment from my physician, and he said, all right, Bonzo, your labs look great. Your cholesterol, your blood pressure is great. Your 10-year heart disease risk is only 2.3%. So keep doing what you're doing. So for me, I said, well, 2.3% is good because it's well less than 7.5%, which is the cutoff that we use in medicine. But I said that number is still a little bit higher than I expected it to be. Like I've really been going crazy, exercising and eating healthy and everything for the last few years. Those numbers are pretty great. I'm surprised it's that high. So me being the type of physician that I am, I went out when I got home and pulled out my little, again, my medical calculator and calculated my labs, my results by, on my own and repeated them. And I got the same exact result. And I said, oh, 2.3%, exact same number my doctor told me. Okay. But then I said, I wonder what my race would be, what my results would be if I plugged in some different numbers. So I started doing things like making my blood pressure lower, higher, making my cholesterol better or worse, just to see what numbers I would get. And then I also changed my age and said, if I have these numbers at age 50, what would my heart disease risk look like? Oh, still pretty good, excellent. And then I said, I wonder what would happen if I changed my race to white and used the same numbers I had. And my risk dropped down by almost 6-fold.
Wow.
And that's when it became, like you said, personally, how do I as a Black man feel about it? That's when I stopped and said, wow, wait a second. You're telling me with the same exact numbers, just by me being white, you're going to say I have almost a 6-fold decreased risk of heart disease. So it's either one or two things. Either one is that's just crazy that Black people have that kind of risk, or two, this is not based on great medicine. They don't know anything about me from this calculation. They have my lab results, they have my demographics, but they don't know if I'm stressed out every day. They don't know if I have health insurance, if I have great access to medical care. They don't know if I use drugs. They don't know if I have a sedentary lifestyle. This result doesn't factor in if I have prediabetes. It doesn't factor in if I'm obese. So I said, so you're telling me that a white obese person with prediabetes who has a sedentary lifestyle and uses drugs has a higher risk than I do? I don't believe that. But again, these calculations just make wide assumptions based on your race. So then, of course, the next step.
Let me ask you this, Dr. Reddick, as far as, and my apologies for cutting you off, but this is very important. Who discovered this? How did this even come about with even starting this calculator to separating Black from white like this? I just, it's kind of mind-boggling. And why, is there any more doctors that is raising their voice to the top of their lungs saying, hey, we are really making this a racial issue with putting their numbers higher than someone's white or someone that's Asian?
Yeah, and so this is actually the calculation that was created by the American College of Cardiology and the American Heart Association. And it is based on some population level data. So if you look at Black people in America, they are more likely to have higher rates of heart disease, higher rates of high blood pressure. They're more likely to live a sedentary lifestyle. They're more likely to have a high calorie diet, more likely to have a diet that's higher in sodium and lower in potassium. Those are things that are not good for your heart. And so it is based on general trends in these racial categories.
But isn't that a domino effect of a lifestyle? And I know that, I want to stay on subject here, but isn't that someone that's living in poverty? Isn't that a generational thing that Blacks can afford, or, to live a high lifestyle, to eat healthy every day?
Yeah, and so that's what we refer to as the social determinants of health. So these are the social factors, the non-medical, the non-biological factors that affect people's health. And the problem with these calculators is it does not consider those social determinants of health. Now, to the point of to kind of be fair to the American College of Cardiology and the American Heart Association, they actually did publish an update that actually kind of started to backtrack a little bit from this calculation and said, well, you should also consider each individual person's individual context and their social context as you're making these decisions. Because the way this calculator does, just like the kidney function calculator does, it makes the impression that Black people are completely different from everybody else on the planet. In that kidney equation I told you about, there's one calculation for Black people and there's one for everybody else. This calculator may make it seem like there's differences between races, but if you type in another race that's not Black, you'll get the same result. So what I noticed when I was doing this,
for the kidney, lungs, and your heart, or is there other calculators that we as Black people need to know about?
Oh, there's a bunch. There's a bunch out there. There's a calculator for determining your risk of having a successful vaginal delivery if you've had a C-section that includes race. That one did get recently updated to a group from the Society of Maternal Fetal Medicine. Did just recently create a calculator that does not have the race factor in it. For determining somebody's bone mineral density, somebody's risk of a bone fracture from osteoporosis, they call it the FRAX score. That one also considers people race in it. And again, the thing is, a lot of times it's kind of either you're Black or you're not Black. Again, this perception that Black people are just different from everybody else on the planet. Because again, on this calculator you have right here, you'll notice in that kind of a third away from the bottom where it says race, notice it says white/other. Like no matter what race you put in, if it's not Black, it just says white/other, you get the same exact result.
And I'm not saying that, and I want to make sure that we're clear on this platform that no, it's not the average white person's fault that they have these calculators, but we have to understand how a Black person may feel that's listening to this, or if it's in the media that they know what's literally going on, it's going to look like the American Heart Association is racist. But of course, I'm not blaming the person itself, but the development and their process is appearing to be racist. So I want to steam back to a question that I have known for you to ask. Why is being Black more dangerous than smoking?
Yeah, so you jump right to it. This is one of my favorite things to say. So when I was playing around with this calculator, one of the things that I popped in was I actually said, okay, no matter what I do with the numbers, the white person always seems to be healthier. If I make their blood pressure higher, their cholesterol higher, they still tell me that my race it still makes me a higher risk in terms of my heart disease risk. So when I was playing around with the numbers, I actually put in my same numbers and I changed the white person to a smoker, and they still had a lower risk. So that's where I kind of joke around and say being Black is more dangerous than smoking, because literally, according to these calculators, same exact demographic, same age, same gender, same cholesterol, same blood pressure, everything the same. And the white person is a smoker, and they're still considered to have a lower risk than the Black person. And so you raised a couple great points. Is that a lot of people say, well, gosh, this sounds terrible, this sounds awful, this sounds racist. Right. And again, what is really probably more of a reflection on is that we've just put so much stock in the way we define race, and we assume it's based on something real, something scientific, because it's been like that since the 1800s. The person that actually created that spirometer device I was talking about, for measuring lung function, was actually a doctor of what they call slave medicine. And he noticed that there were differences in the lung function of enslaved Africans compared to other people. He didn't consider the social factors. He didn't consider the fact that they were enslaved, the fact that they were living in terrible conditions, that they were standing over those coal burning stoves all day long, out in the elements, sleeping with pigs on the ground, that those things actually affected the allergens, the cockroach and the dust allergens actually affected their lung function. He assumed that there was just a racial difference, that Black people were just genetically different from everybody else. And that, unfortunately, has kind of still continued to stay in our minds and in our medical system for a long time, where people just accept these weird social definitions that we have of race and act like there's a biological or a genetic pattern to them.
But what I can't understand is as smart as America is, I mean, you're literally sitting here telling me that a doctor back in the 1800s is going off of slave medicine, and we don't understand by now that of the conditions that they were in. So that's what's mind-boggling to me, that this is still going on. And I have to raise the question, will this ever change, or is this still going to be like this? Because now I've came of knowledge of knowing. So, any of my family members, hey, now I'm going to question, okay, what's in your calculator? And are you doing the right thing? Because if the word is not out, if people don't know about it, and I'm grateful for this platform here on Health Connect South, because it's so important that we have these dialogues and messages like this. So can you tell me, Dr. Reddick, how is this message being spread to the masses?
So that's a fantastic question. You actually raised like three fantastic points right there. So I'll try to get to all three of them really quickly. One, as far as patient goes, this is one of my concerns I've had, is that there has not been informed decision-making, informed consent in this process. So a lot of times when you go to the doctor and you get your blood drawn, you get your cholesterol checked, they'll say, hey, your heart disease risk is this %, so you need this medicine. Or you need this statin medication. Or your heart disease is this %, so your heart disease risk is this %, so you need this aspirin for prevention of heart disease. But there's no discussion saying, you know what, this is based on some very questionable science, based on general trends of populations, of Black populations, but it's not really very good in making individual decisions because Black people are very heterogeneous. They're very, very different from each other. So it's based on kind of sketchy evidence, but I just wanted to let you know that there's this calculator. If I put you in as Black, this is what number I get. If I put you in as white, this is what number I get. It's based on general stereotypes that Black people are more sedentary, have higher calorie diets, more sodium, less potassium in their diet, higher rates of obesity. That's what it's based on. And then you allow the patient to decide what they want to do. The patient can say, well, you know what, I'm not gonna lie, that kind of sounds like me, so I'll go ahead and be safe and I'll be more aggressive with my care. Or they could say, that doesn't sound like me. I'm, vegetarian.
Right.
I exercise on a regular basis. I think I'll not use that race correction. But we don't do that. We don't do that with kidney function. We don't tell a patient, hey, you know what, this says that your kidney function is okay, but that's because they use the Black correction. If you don't, it actually says you have some mild chronic kidney disease. Would you like us to refer you to a specialist, or not? And let the patient be involved in that decision. We don't do that in medicine hardly ever. I've done polls of physicians before, and I know one time I was in front of an audience of a couple hundred people, and I only had 2 physicians out of the entire audience say they had ever done that with their patients.
That's literally insane. And I literally have to use that word, insane, because it's almost like you are falsely diagnosing to a certain extent and not, and I want to be careful how I say this because I'm not saying that the doctor didn't, get the right education, but the education that he received, they got it wrong from the top. So I have to ask Dr. Reddick, do you get any backflip from really discussing your points on recognizing this major breaking news about the calculators, the racial calculators?
So it's interesting. You mentioned earlier, like about the backlash, and you also mentioned about, is this changing at all? The good news is that this actually is changing. The GFR equation that I mentioned for kidney disease, there are a lot of hospital systems that stopped reporting their labs, stopped reporting the separate result for Black people. They only result one result for everybody. The hospital system that I work in actually stopped doing this this past fall.
Well,
I know
that's
the University of Washington was kind of one of the leaders in the country that first started doing it. I believe UCSF kind of followed behind them, and there's several other hospital systems, really prominent hospital systems around the country that have stopped doing this. The next step would be for the lab companies themselves, the LabCorp and the Quest and those types of companies to start doing the same thing and stop reporting it as well. Like I said, the American College of Cardiology actually did do an update on this calculator that you still see showing, where they actually said, okay, you really should consider individual people's social context and not just apply these numbers across the board. So we are starting to see a trend. I definitely teach this to our medical students. I was actually invited earlier to the Society of Teachers of Family Medicine National Conference to present this information. Just wrote an editorial on it for the American Academy of Family Physicians Journal. And the American Academy of Family Physicians, the American Medical Association, and several other organizations have recently come out declaring that race is a social construct and not a biological one. So a lot of the medical organizations are coming out and saying that race is not a scientific thing, it's a social construct, and that we should not mistakenly think that it's a good proxy for genetics or biology. And the last thing you mentioned, go ahead, I'm sorry.
No, that's really good to know that that's going on, or I guess you could say the corporate level. But what about down on the ground, boots on the ground, and knowing it from that level?
There's still a lot of pushback and a lot of backlash from that standpoint. I've been talking about this since about 2012, actually. And even as recently as about 2017, it was either 2017 or 2018, I was a member of a health equity group. And when I was presenting this information and said that we should really make this, kind of challenge the national organizations to come out and declare race as a social construct and not a biological one, we should speak out against just using these kind of calculators across the board without considering people's individual social context. And so when I did that, I got a lot of pushback. I mean, just a whole lot of pushback from people. One guy used profanity with me, got really, really upset. One person said, I'm not comfortable putting my name on this kind of stuff. And so I think there's still a whole lot of pushback from individual people because it's uncomfortable. Like, there's always changes in science that happen. And we say, oh, you know what? We used to think you shouldn't use this medicine, but you should. Or we used to think this medicine helped, but it actually doesn't. So we're okay with that. But it's a little more uncomfortable to say, oh, we just didn't have enough information. We didn't know that you shouldn't use this medicine. It's more uncomfortable to say, oh my gosh, there's a lot of Black people who died from kidney disease because we use these outdated equations and ideas that kind of date back to the days of slavery. That's really uncomfortable to do as a medical society. For me, again, I didn't know this either.
Let me ask you this, Dr. Reddick, and sorry to cut you off, but do they feel that lawsuits will come behind it?
I don't think so. I think in general, whenever there's been shifts in medicine, I haven't heard of that happening. So, one of my favorite examples to use is heart failure. That for years, they told us not to use these medications called beta blockers in people who have heart failure. I still have some of my saved textbooks from medical school that say never use beta blockers in heart failure patients. But now, after a while, we learned that beta blockers, especially a few specific ones, do a really good job at actually decreasing the death rates from heart failure. So I never heard about patients that had heart failure coming out suing later on saying you should have used that medicine on me, because it's based on new science. It's, hey, we didn't know any better. And I think this is something we could just say, hey, we didn't know any better. We got kind of wrapped up in the social definition of race. We get pummeled with so many images and views from a young age about differences between races, and not realizing that genetically and biologically we're not all that different. And the way we group people by race is definitely not a consistent, reliable pattern for how to group people in terms of a medical standpoint.
Now, I want to, before we wrap it up, ask a couple more questions. Could you further explain the variations about there being the variations between race?
Yeah. So, and I want to bring up something else you said so I don't forget as well. You mentioned the domino effect, and that's why the question you just asked is so important. So, because it just keeps going and keeps going. Because in terms of kidney disease, you say, okay, you're Black, so your labs are okay. Oh, you're white, you need to see a specialist. And not only that, the Black person also says, hey, based on the blood pressure guidelines, there's certain guidelines that say you should use this medicine in Black people and this medicine in white people. It just so happens the medicine that they say to not use in Black people is a medicine that can actually preserve your kidney function. So you're already telling the Black person, hey, your kidneys are okay, when they're not. You're also saying don't use this medicine that can save your kidneys. And then on top of that, you're saying, hey, you have a high heart disease risk. It's okay, that's just genetic, instead of addressing the social factors that could fix the underlying problems. And then if they happen to be a smoker with lung disease, you say, oh, that's okay, your lungs are fine because you're Black. It just never stops. So if you're a Black woman who's had a C-section and you want to have a vaginal delivery, they'll say, oh, your risk of having a good, successful vaginal delivery is kind of low because you're Black. Like, those are all the things that happen. And the thing about it is that, again, people can pull out studies and say, well, I see these general trends in society in different races. So it's based on true evidence, right? Well, let me kind of use the example that you probably saw a quick second of earlier. Let's use the example of stomach cancer. This is one of my favorite examples that one of my students shared. Because they were saying, well, Dr. Reddick, I know you say that there's no scientific basis for races, but I've seen some patterns that are really, really consistent and really compelling. And I said, well, bring me some examples. And he brought me this example of stomach cancer in Asian people. And he said, see, they have rates that are so much higher than everybody else. It's got to be some racial component, right? Well, if you look at it, I looked at the International Registry of Cancer, the International Cancer Registry, their database, and I pulled up and made a graph of the numbers of the incidence of gastric or stomach cancer. And as you can see, the two highest rates in the country are Japan and Korea. So Japanese and Korean people have the highest rates on the planet, higher than everybody else. What I also found that number 3 was Iran, and number 4 was Russia. And the typical person who's come from those countries, if they come to the US, they'll be identified as white, actually. When I kept going down to other Asian countries, I saw that China's rate is less than half of what it is in Japan and Korea. And then if you just go different places within China, you see differences. So if you go from mainland China, you see higher rates than if you see for people who are Chinese living in Hong Kong. And then what I really found was interesting is that when you go to the Philippines and into Thailand, their rates are pretty similar to white Americans. And then also the average Asian or Pacific Islander who moves to the United States, them and their descendants actually have rates of stomach cancer that are pretty similar to white Americans. So what we found is that it's more where you are, the country and the environment around you, not your race. Right. And then even within that, if you split it up to within city to city, neighborhood to neighborhood, you see completely wide differences. So the point is, there's more difference between somebody who's Japanese and somebody who's Thai than there is between a Korean person and a Black person in America.
Because of location.
Yeah, and even within location, there's differences even from city to city, neighborhood to neighborhood. So even from zip code to zip code. So even just saying, okay, well, we got to do a better job of separating people out by country, that doesn't work either. Because as you can see, you get a different result in Shanghai versus in Hong Kong. And if you split it up by groups within that, you'll get differences between Han Chinese and Hmong. And then within those groups, if you look at Han Chinese in this city versus that city, you'll get different results. There's more variation within races than between races. Again, somebody from Korea is more different from somebody from the Philippines than they are from a Black American. They're more similar to me than they are. A Korean person is more similar to me than they are to a person from Thailand in terms of stomach cancer risk.
So, Dr. Reddick, let me ask you this. How can you get the message out? You're a fairly young man. You know your stuff. You dug deep into the knowledge of how these calculators are being determined, and also how it affects people, Black people in general. How could you bring the message out even more? As I say,
one example, I'm sorry.
No, as just boots on the ground.
So I use the example of, again, because I have that personal story that I love to tell. That's something that's kind of provocative. It kind of gets people's attention when I say being Black is more dangerous than smoking, y'all.
But that really
gets people, which just gets people attention. But it's a good talking point, kind of lead off point to discussion, because two things. One is that in general, Black people do have, as a population, have higher rates of certain diseases, and there's social factors that are reasons for that. But the second thing is we need to do a better job of also treating each person like an individual and not making assumptions about general groups of people. You can make population level interventions for certain communities, but also at an individual level, you still need to treat each person like a patient. I use that, but there's a million examples for other racial categories as well. Same thing happens with stomach cancer. Can you imagine if we use that same logic and say, oh, if somebody comes in with stomach symptoms and they're Asian, we should be more aggressive with their medical care. Again, that's not a reliable thing, because way different results from Japan versus Thailand versus the Philippines versus Korea versus Shanghai versus Hong Kong, completely different results, and that's not reliable. So the message, I think, starts with the physicians in training, letting them see things like this, not just physicians, but all healthcare professionals. So physician assistants, nurse practitioner students, medical students, whatever it may be, genetic counselors in medicine, making sure they understand these concepts and understand that these general trends are based on just general population trends related to social factors, and that you can't apply them to individual people. So that's important to get out in terms of the future generation of physicians. For people that are scientists who are creating these lab tests and people who are running these lab companies, we've got to get that same message to them. So my call to action would be for anybody who's educating medical educators. It would be to healthcare organizations who are running these systems, saying, hey, let's take a look at what our lab systems is doing and how they're reporting these things. Let's also look at individual patients and educating them about the social factors, doing a better job of addressing social determinants of health. And then finally, for the CEOs, the insurance companies, incentives for actually interventions in the community that actually improve the health of people and address these social factors. And again, for anything anybody throws at me and says, well, what about this, what about that? Trust me, it never ends. If you use the example of ethnicity, you'll get the same kind of results that I gave you today. They're all over the place. So that's kind of my call to action, is for educators, for healthcare systems, for CEOs, for people who own lab companies, to do away with this race-based medicine ideology and really address these social determinants of health.
Well, it's, first of all, thank you so much for really enlightening me and literally enlightening the world on these issues, because I can tell you probably 90% of Americans that's not in the medical field even know this information. And it's so vital, it's so key that Black Americans, Black people, people of color, let me just say that, people of color, the darkest skin, need to know information like this, because we could probably save lives. And that's just the hard truth of it. But it's such an honor to have, and you already answered my question about the call to action. What can you tell, other people in the medical field that is doing this, having this knowledge and really, I guess, seeing patients, just being more real with their patients and being honest. And so I hope that there's more leaders. I hope there's more doctors like you that can really get truth out, instead of what they learn, knowing that that's not really the truth. Would you like to wrap up with anything, Dr. Reddick?
Yeah, I think that's it. That's the call to action, is just for our healthcare, anybody who might be listening to this, if you're a leader of a healthcare organization, take a look at your lab processes, have these discussions with your physicians and your healthcare providers, your nurse practitioners, PAs, whoever it may be, and see if they're taking the social determinants of health and not a biological determinants of health when it comes to racial and ethnic health disparities. And also for the the healthcare organizations becoming more involved in communities and addressing these social factors and addressing the root cause and not blaming everything on skin color, but saying, hey, there's some significant social factors we need to address in society, and those things will improve the health of our communities.
Thank you so much for joining me on Health Connect South.
Thank you so much.